Foundations of Maternal Newborn and Women's Health Nursing by Murray, McKinney, Holub, and Jones, 7th edition. Chapter 20, Assessment of the Normal Newborn. A very important role of the nurse is assessing the newborn to identify abnormalities and problems in adapting to life outside the uterus. The first complete assessment of the newborn is often called an admission assessment. Subsequent assessments are less detailed. Early focused assessments. As soon as the infant is born, the nurse performs assessments that are most immediately crucial to determining the neonate's health status. These include the cardiorespiratory status, muscle tone, thermoregulation, estimation of the gestational age, and presence of anomalies. The nurse determines whether resuscitation or other immediate interventions are necessary. If no anomalies are present and the newborn is adapting to extrauterine life without difficulty, the nurse should facilitate parent-infant attachment and initiation of breastfeeding while continuing ongoing assessments of breathing, activity, and color. Completion of a more thorough admission assessment follows. If possible, this assessment should be performed in the mother's room to provide an opportunity for parent teaching and continued parent-infant attachment. History. Information about the pregnancy, labor, and birth is important in assessing the likelihood of problems. The gestational age, maternal age, health problems, and any complications during the pregnancy or birth may affect the neonate's adaptation. For example, if the mother received narcotic analgesics late in labor, depression of the fetal central nervous system may interfere with initiation of respirations in the neonate. Preterm infants may not produce adequate amounts of surfactant, and atelectasis may occur because the alveoli do not remain open. Assessment of cardiorespiratory status. Assessments of respiratory and cardiovascular status are performed together because transitional changes take place simultaneously in both systems. Problems of adaptation in one system are likely to result in problems in the other system. Airway. During birth, some fetal lung fluid is forced into the upper airway and expelled. Excessive fluid and mucus in the infant's respiratory passages may cause respiratory difficulty for several hours after birth. Respiratory rate. The nurse assesses respirations at least once every 30 minutes until the infant has been stable for 2 hours after birth. If abnormalities are noted, respirations are assessed more often. The normal respiratory rate is 30 to 60 breaths per minute. The average rate is 40 to 49 breaths per minute. The infant may breathe faster immediately after birth, during crying, and during the first and second periods of reactivity. Respirations should not be labored, and the chest movements should be symmetric. Because the pattern and depth of respirations are irregular, they must be counted for a full minute for accuracy. Counting the rapid, shallow, irregular respirations of a newborn can be a challenge at first. Differentiating between the respirations and other movements while observing the infant's chest may be difficult. Observation, auscultation, or palpation, alone or in combination, may be used to obtain an accurate respiratory rate. The nurse observes for periodic breathing, pauses in breathing lasting 5 to 10 seconds without other changes, followed by rapid respirations for 10 to 15 seconds. This occurs in some full-term infants during the first few days, but is more common in preterm infants. Apnea is a pause in breathing lasting 20 seconds or more, or accompanied by cyanosis, pallor, bradycardia, or decreased muscle tone. Apnea is abnormal and requires prompt intervention. Breath sounds. The anterior and posterior lung fields are auscultated for breath sounds, which should be present equally throughout. Breath sounds should be clear over most areas. However, hearing crackles in the lungs during the first hour or two after birth is not unusual because fetal lung fluid has not been completely absorbed. Infants born by cesarean, not preceded by labor, do not experience the changes that occur in the lungs during labor and birth and are more likely to have coarse breath sounds for a short time. Wheezes, crackles, rhonchi, or stridor that persist should be reported. Abnormal and diminished sounds should be reported to the primary provider if they continue. They may indicate a pneumothorax. Bowel sounds in the chest may be a sign of diaphragmatic hernia. Signs of respiratory distress. Throughout the assessment, the nurse must be alert for signs of respiratory distress, which may be present at birth or develop later. Whenever one sign of labored breathing is present, the assessment must be carefully expanded to identify others. Tachypnea. Tachypnea, a respiratory rate of more than 60 breaths per minute, is the most common sign of respiratory distress. It is not unusual during the first hour after birth and during the periods of reactivity, but continued tachypnea is abnormal. Retractions. Retractions occur when the soft tissue around the bones of the chest is drawn in with the effort of pulling air into the lungs. Xiphoid substernal retractions occur when the area under the sternum retracts each time the infant inhales. When the muscles between the ribs are drawn in so that each rib is outlined, intercostal retractions are present. Muscles above the sternum and around the clavicles also may be used to aid in respirations, supraclavicular retractions. Retractions may be mild or severe, depending on the degree of respiratory difficulty. Occasional mild retractions are common immediately after birth, but should not continue after the first hour. Flaring of the nares. A reflex widening of the nostrils occurs when the infant is receiving insufficient oxygen. Nasal flaring helps decrease airway resistance and increase the amount of air entering the lungs. Intermittent flaring may occur in the first hour after birth. Continued flaring indicates a more serious respiratory problem. Cyanosis. Cyanosis is a purplish-blue discoloration indicating the infant is not getting enough oxygen. It may be preceded by a dusky or gray hue to the skin. Central cyanosis involves the lips, tongue, mucous membranes, and trunk and indicates true hypoxia. This means that not enough oxygen is reaching the vital organs and requires immediate attention. Bruising of the face may occur from a tight knuckle cord or pressure during birth and may look like central cyanosis. To differentiate cyanosis from bruising, apply pressure to the area. A cyanotic area will blanch, but a bruised area remains blue. Central cyanosis in infants with dark skin tones can be checked by looking at the color of the mucous membranes. A pulse oximeter is used to determine oxygen saturation in infants with cyanosis. Central cyanosis must be differentiated from acrocyanosis, which is peripheral cyanosis involving only the extremities. Acrocyanosis is normal during the first day after birth and if the infant becomes cold. It results from poor perfusion of blood to the periphery of the body. Cyanosis may be present at birth or may become apparent later. It is normal to see a cyanotic infant at birth whose color quickly turns pink as the infant begins to breathe. Cyanosis occurs whenever the infant's breathing is impaired. It may occur during feedings because of difficulty in coordinating sucking, swallowing, and breathing. Infants who become cyanotic on exertion or when crying may have a congenital heart defect. Grunting. Grunting describes a noise made on expiration when air crosses partially closed vocal cords. This increases the pressure within the alveoli, which keeps the alveoli open and enhances the exchange of gases in the lungs. Grunting may be very mild and heard only with a stethoscope, or loud enough to be heard unaided in an infant having severe respiratory difficulty. Persistent grunting is a common sign of respiratory distress syndrome and necessitates expanded assessment and referral for treatment. Seesaw or paradoxical respirations. Normally, the chest and abdomen rise and fall together during respiration. In the infant with severe respiratory difficulty, the chest falls when the abdomen rises, and the chest rises when the abdomen falls, causing a seesaw effect. Asymmetry. Chest expansion should be equal on both sides. Asymmetry or decreased movement on one side may indicate the collapse of a lung, pneumothorax. Choanol Atresia. Choanol Atresia is blockage or narrowing of one or both nasal passages by bone or tissue. Assessment for choanal atresia is important because newborns are preferential nose breathers for approximately the first 4 to 6 weeks of life. This means they breathe mostly through the nose except when crying. Bilateral choanal atresia causes severe respiratory distress and requires surgery. Blockage of one side puts the infant at risk for respiratory distress if the other side becomes occluded by mucus or edema. The nurse can assess for choanal atresia by closing the infant's mouth and occluding one nostril at a time. The infant is observed for breathing, and breath sounds are auscultated while each nostril is occluded. Another method of assessment is to pass a catheter through each nostril to check for patency. Infants with choanal atresia may become cyanotic when quiet, but pink when crying because air is then drawn in through the mouth. Color. In addition to cyanosis, the nurse assesses for pallor and ruddiness. Pallor. Pallor can indicate that the infant is slightly hypoxic or anemic. A laboratory examination of hemoglobin and hematocrit or a complete blood count may be ordered. Ruddy color. A ruddy or reddish skin color, plethora, may indicate polycythemia, an excessive number of red blood cells. Hematocrit value above 65% confirms polycythemia. Infants with elevated hematocrit levels are at increased risk for jaundice from the normal destruction of excessive RBCs that occurs after birth. Heart sounds. The heart is auscultated for rate, rhythm, and the presence of murmurs or abnormal sounds. The nurse should count the apical heart rate for a full minute for accuracy and listen for abnormalities. The rate should range between 120 and 160 beats per minute (BPM) with normal activity. It may elevate to 180 BPM when infants are crying or drop to as low as 100 BPM when they are in deep sleep. If there are no problems present at birth, the heart rate should be recorded at least once every 30 minutes until the infant has been stable for 2 hours after birth. Monitoring is more frequent if abnormalities are present. Once stable, the heart rate is checked every 8 to 12 hours or according to hospital policy unless a reason for more frequent assessment develops. Position. The apex of the heart is located at the point of maximum impulse, where the pulse is most easily felt and the sound is loudest. This is at the third or fourth intercostal space, lateral to the midclavicular line. Conditions that affect the position of the heart include pneumothorax and dextrocardia, or right to left reversal from the normal heart position. Rhythm and murmurs. The rhythm of the heart should be regular, and the first and second sounds should be heard clearly. Abnormalities in rhythm and sounds, such as murmurs, should be noted. Murmurs are sounds of abnormal blood flow through the heart and may indicate openings in the septum of the heart or problems with blood flow through the valves. They occur in approximately 10% of newborns. Most murmurs in the newborn are temporary and result from incomplete transition from fetal to neonatal circulation. A murmur is common until the ductus arteriosus is functionally closed. Although it may be a normal or functional murmur, any abnormal sounds of the heart are investigated because they may be signs of cardiac defects. Pulse oximetry screening for cardiac defects is often performed before discharge. Brachial and femoral pulses. The brachial and femoral pulses should be present and equal bilaterally. The brachial pulse is located over the antecubital space, and the femoral pulse is located at the groin. Pulses should be equal bilaterally, and the brachial and femoral pulse rates should be the same. Femoral pulses that are weaker than the brachial pulses may result from impaired blood flow in coarctation of the aorta, a congenital heart defect. In this condition, a narrowed area of the aorta impedes blood flow to the lower part of the body and causes weaker pulses in the lower extremities. Blood pressure. Measurement of blood pressure is not necessary part of a routine assessment of the newborn. However, the BP is taken on all extremities if the infant has unequal pulses, murmurs, or other signs of cardiac complications. Doppler ultrasonography or other electronic measurement techniques are used. For accurate measurement, the infant should be quiet when the BP is taken because crying elevates it. The width of the BP cuff should be 40 to 50% of the circumference of the arm or leg, or 25 to 50% wider than the diameter of the limb. The average BP for full-term newborns is 65 to 95 systolic and 30 to 60 diastolic. BP varies according to the infant's age, weight, and gestational age. Hypotension may occur in the sick infant. The BP of the lower extremities should be the same or slightly higher than that of the upper extremities. A systolic BP in the upper extremities that is greater than 20 points higher than that in the lower extremities may indicate coarctation of the aorta. Capillary refill. Capillary refill is assessed to help determine whether perfusion is adequate. It is checked by depressing the skin over the chest, abdomen, or an extremity until the area blanches. The color should return within less than 3 to 4 seconds. Assessment of thermoregulation. The neonate's temperature is taken soon after birth while the infant is being held by the mother, or in a radiant warmer with a skin probe attached to the abdomen. The probe, which should not be attached over bony prominences or areas of brown fat, allows the warmer to measure and display the infant's skin temperature continuously. Temperature control is set to regulate the amount of heat produced according to the infant's skin temperature. The temperature should be assessed at least once every 30 minutes until the infant has been stable for 2 hours after birth. It is often checked again at 4 hours and then once every 8 to 12 hours, or according to facility policy, as long as it remains stable. The most common method of taking the neonate's temperature is axillary measurement. The normal range for axillary temperature is 36.5 to 37.5 Celsius. Taking axillary temperatures is safer than taking rectal temperatures because it avoids the possibility of irritation or injury to the rectum, which turns at a right angle approximately 3 centimeters from the anal sphincter. The location always should be charted along with the temperature measurement. If a rectal temperature is necessary, the nurse should use great caution because inserting the thermometer too far could cause potentially fatal perforation of the intestinal wall. A thermometer should never be forced into the rectum because of the possible presence of an imperforate closed anus. Temperatures are usually measured with an electronic digital thermometer. Inexpensive digital thermometers used while the infant is in the hospital are often given to the parents for home use. Tympanic thermometers used in some facilities for older infants and children are not recommended for newborns. Some agencies use temporal artery thermometers. General assessment. If major abnormalities are present at birth, the nurse must maintain a calm, quiet demeanor to avoid frightening the parents. The providers should be alerted quietly and will explain the condition and possible plan of treatment to the parents. Head. The newborn's head and neck constitute 1/4 of the body surface. It is much larger in proportion to the rest of the body than that of the adult. The head is palpated to assess the shape and identify abnormalities. The newborn, who is delivered by cesarean, not preceded by labor, usually has a round head, whereas the infant born vaginally usually has some molding. The head of infants who are in a breech position may be flattened on the top. The degree of molding, size of the fontanelles, and presence of the Kappa Succidanium or later development of Cephalo Hematoma are noted. The hair should be fine with a consistent pattern. Abnormal hair growth patterns may indicate genetic abnormalities. The nurse separates the hair, if necessary, to display bruises, rashes, or other marks on the scalp. A small red mark is apparent if a fetal monitor electrode was inserted into the skin of the scalp. Later, a small scab forms. Occasionally, this area becomes infected and a topical antibiotic is applied. Molding. Molding refers to changes in the shape of the head that allow it to pass through the birth canal. It is caused by overriding of the cranial bones at the sutures and is common, especially after a vaginal delivery. The parietal bones often override the occipital and frontal bones, and a ridge can be felt at those areas. The condition generally resolves within a few days to 1 week after birth. Often, dramatic improvement is seen by the end of the first day of life. Parents may need reassurance that the infant's head is normal. All sutures should be palpated. Separation may be the temporary result of molding, or if it persists or widens, may indicate increased intracranial pressure. If no space is found between suture lines, it may be the result of molding and overriding of the bones. However, a hard, ridged area, not resulting from molding, may indicate premature closure of the sutures. This condition, called craniosynostosis, may impair brain growth and the shape of the head and requires surgery. Fontanelles. The fontanelles are the areas of the head where sutures between the bones meet. In the newborn, the areas are not calcified, but are covered by membrane to allow space for the brain to grow. The nurse palpates the fontanelles and notes the position in relation to the other bones of the skull. The infant's head is elevated during palpation for accurate assessment. The infant may be placed in a semi-sitting position or held in an upright position. The fontanelle should be palpated when the infant is quiet because vigorous crying may cause it to protrude. The anterior fontanelle is a diamond-shaped area where the frontal and parietal bones meet. It measures 4 to 6 centimeters from bone to bone, although this varies because of molding and individual differences. The fontanelle closes by 18 months of age. The anterior fontanelle should be soft and flat, level with the surrounding bones, or only slightly sunken. After molding resolves, a depressed fontanelle may be a sign of dehydration. Although the anterior fontanelle may bulge slightly when the infant cries, bulging at rest may indicate increased intracranial pressure. A fontanelle that is between flat and bulging is termed full. A larger than normal fontanelle may be a sign of increased pressure within the skull. Abnormal signs are reported to the primary care provider. The posterior fontanelle is a triangular area where the occipital and parietal bones meet. It is much smaller than the anterior fontanelle, measuring 0.5 to 1 centimeter, and feels like a dimple at the juncture of the occipital and parietal bones. This fontanelle closes by the time the infant is 2 months of age. Kappa Succidanium. A Kappa Succidanium is an area of localized edema that appears over the vertex of the newborn's head as a result of pressure against the mother's cervix during labor. The pressure interferes with blood flow from the area, causing localized edema at birth. The edematous area crosses suture lines, is soft, and varies in size. It resolves quickly and generally disappears within 12 to 48 hours after birth. Kappa also may occur when a vacuum extractor is used to assist birth. When a vacuum is used, the caput corresponds to the area where the extractor was placed on the skull. The amount of edema and presence of bruising are assessed. Cephala Hematoma. A Cephala Hematoma, bleeding between the periosteum and the skull, is the result of pressure during birth. It occurs on one or both sides of the head, usually over the parietal bones. The swelling may not be present at birth, but may develop within the first 24 to 48 hours. The area is carefully palpated to determine whether the swelling crosses suture lines. A Cephala Hematoma has clear edges that end at the suture lines. It does not cross the suture lines, unlike a Kappa Succidanium, because the bleeding is held between the bone and its covering, the periosteum. A Cephala Hematoma reabsorbs slowly and may take 2 to 3 months to completely resolve. Because of the breakdown of the RBCs within the hematoma, affected infants are at greater risk for jaundice. Bruising also increases the risk for jaundice. Both Kappa Succidanium and Cephala Hematoma may be frightening to the parents. They need reassurance that the conditions are not harmful to the infant. Even if parents do not ask, they need information about the causes and length of time required for the areas to resolve. Face. The face is examined for symmetry, positioning of the facial features, movement, and expression. A transient asymmetry from intrauterine pressure may occur, lasting a few weeks or months. Drooping of the mouth appears as a one-sided cry and may be caused by facial nerve trauma. Irregularities of the facial features should be reported. Neck and clavicles. The nurse assesses the infant's neck visually and notes the ease and extent with which the head turns from side to side. The neck should have full range of motion. It is very short. Webbing or an unusually large fat pad between the occiput and the shoulders may indicate a chromosomal anomaly. No masses should be present. When lying in a prone position, the term newborn should be able to raise the head briefly and turn it to the other side. Fractures of the clavicle are more likely to occur in large infants, especially when shoulder dystocia occurred. Sliding the fingers along each clavicle while moving the infant's arm helps identify a fractured clavicle. If a fracture is present, a lump, swelling, or tenderness over the bone may be observed. Crepitus, grating of the bone, and movement of the bone may be felt during palpation. Decreased movement of the affected arm also may occur. A difference in the movement of the arms is especially noticeable when the Moro reflex is elicited. Injury to the brachial plexus may cause paralysis of the arm on the side of the fracture. Treatment of a fractured clavicle includes immobilization of the affected arm for a short time. The fracture heals quickly. Umbilical cord. The umbilical cord should contain 3 vessels. The 2 arteries are small and may stand up at the cut end. The single vein is larger than the arteries and resembles a slit because its walls are more easily compressed. If only one artery is present, the infant is carefully assessed for other anomalies. A 2-vessel cord may be an isolated abnormality or associated with chromosomal and renal defects. The amount of Wharton's jelly in the cord is noted. If the cord appears thin, the infant may have been poorly nourished in utero. A yellow-brown or green tinge to the cord indicates that meconium was released at some time before birth, perhaps as a result of fetal compromise. No redness or discharge from the cord should be present. Extremities. The infant should actively move the extremities equally in a random manner. The extremities of a term infant should remain sharply flexed and resist extension during examination. Poor muscle tone results in a limp or floppy infant, which may occur from inadequate oxygenation during birth, but should resolve within a few minutes as oxygen intake increases. Continued poor muscle tone may result from prematurity or neurologic injury. Infants with previously good muscle tone may show decreased flexion if they become hypoglycemic or experience respiratory difficulty. All extremities are examined for signs of fractures such as crepitus, redness, lumps, or swelling. Lack of use of an extremity may indicate nerve injury that may occur with or without fractures. Injury to the brachial nerve plexus may result in Erb's palsy, Erb Duchenne paralysis, paralysis of the shoulder and arm muscles. Instead of the usual flexed position, the affected arm is extended at the infant's side with the forearm prone. Movement of this arm is diminished during the Moro reflex. The condition is treated by splinting, exercise, or both. Hands and feet. The fingers and toes are examined for extra digits, polydactyly, and webbing between digits, syndactyly. Extra digits are often small and may not have bones. Tying the extra digits with sutures causes them to atrophy and fall off. The presence of a bone in the extra digit requires surgical removal. Webbed fingers or toes may be corrected by surgery. Nails in a term infant should extend to the end of the fingers or slightly beyond. The creases in the hands also are examined. Normally, 2 long transverse creases extend most of the way across the palm. A single crease parallel with the base of the fingers that crosses the palm without a break is called a simian crease or line. It may be seen with incurving of the little finger in Down syndrome, trisomy 21. The simian line alone is not diagnostic of trisomy 21, however, and may occur in 5% to 10% of normal infants. The feet are assessed for talipes equinovarus, or clubfoot, a common malformation of the feet. If a foot looks abnormal, it should be gently manipulated. If it moves to a normal position, the abnormality is probably temporary, resulting from the position of the infant in the uterus. In true clubfoot, the foot turns inwards and cannot be moved to a midline position. Casting and manipulation are the usual treatment, but in some cases surgery is necessary. Hips. The hips are examined for signs of developmental dysplasia. In this condition, instability of the hip joint occurs and the head of the femur can be moved in and out of the acetabulum. Partial dislocation and inadequate development of the acetabulum may occur. Identifying a hip problem early is important to prevent permanent damage to the joint. The infant's knees should be bent with the feet flat on the bed to compare the height of the knees. If the hip is dislocated, the knee on the affected side is lower. The legs are extended with the infant in the prone position to determine whether they are equal in length and if the thigh and gluteal creases are symmetric. If the hip is dislocated, the leg on the affected side is shorter and the creases are asymmetric. Because the hip may be unstable but not yet dislocated, these signs may not be present at birth. Barlow and Ortolani tests are methods of assessing for hip instability in the newborn period. These maneuvers are performed by the physician or advanced practice nurse. Both legs should abduct equally in normal infants. Abducting the affected hip may be difficult. A hip click may be felt or heard, but is usually normal and is different from the clunk of hip dysplasia when the femoral head moves in the hip socket. Treatment of developmental dysplasia of the hip involves immobilizing the leg in a flexed, abducted position, usually with a harness. Early identification and treatment are essential to provide the best results in correcting the problem. Treatment may involve casting or surgery if the condition is not discovered early. Vertebral column. The nurse palpates the entire length of the newborn's vertebral column to discover any defects in the vertebrae. An indentation is a sign of spina bifida occulta, failure of the vertebra to close. The defect is not obvious on visual inspection because it is covered with skin. But sometimes a tuft of hair grows over the area. Other more obvious neural tube defects include a meningocele, protrusion of spinal fluid in meninges, or a myelomeningocele, protrusion of spinal fluid, meninges, and the spinal cord through the defect in the vertebrae. They appear as a sac on the back and may be covered by skin or only the meninges. The Tissue should be covered with moist, sterile saline dressings immediately after birth. A pilonidal dimple may be present at the base of the spine. It should be examined for a sinus and the depth noted. Measurements. Measurements provide information about the infant's growth in utero. The weight, length, and head and chest circumferences are part of the initial assessment. The measurements are compared with the norms for the infant's gestational age. When a difference is noted between the expected and actual values, expanded assessments are necessary. Weight. The weight of the term newborn ranges between 2,500 and 4,000 grams, 5 pounds 8 ounces, and 8 pounds 13 ounces. If the infant's weight is outside the normal range, possible causes are assessed. Factors affecting weight include gestational age, placental functioning, genetic factors such as race and parental size, and maternal diabetes, hypertension, and substance abuse. Infants are weighed each day they are in the birth facility and at follow-up visits. They can be expected to lose up to 10% of their birth weight during the first week of life. The loss results from excretion of meconium, normal loss of extracellular fluid, and inadequate intake of calories during the first few days. Infants normally regain or exceed their birth weight by 14 days of life. Thereafter, they gain approximately 30 grams per day during the early months. Length. The infant's length is measured from the top of the head to the heel of the outstretched leg. The average length of a full-term newborn is 48 to 53 centimeters, 19 to 21 inches. Some agencies also record the crown-to-rump measurement, which is approximately equal to the head circumference. Head and chest circumference. The diameter of the head is measured around the occiput just above the eyebrows. The normal range of head circumference for the term newborn is 32 to 38 centimeters, 13 to 15 inches. The measurement may be affected by molding of the skull during the birth process. If a large amount of molding occurred, the head is remeasured when it regains its normal shape. An abnormally small head may indicate poor brain growth and microcephaly. A very large head may be a sign of hydrocephalus. The chest is measured at the level of the nipples. It usually is 2 to 3 centimeters smaller than the head. The normal circumference of the chest is 30 to 36 centimeters, 12 to 14 inches. If molding of the head is present, the head and chest measurements may be equal at birth. Assessment of body systems. Neurologic system, reflexes. Assessment of the reflexes is important to determine the health of the newborn's CNS. The nurse notes the presence and strength of the reflexes and whether both sides of the body respond symmetrically. A diminished overall response occurs in preterm and ill infants. Absence of reflexes may indicate a serious neurologic problem. Asymmetric responses may indicate that trauma during birth caused nerve injury, paralysis, or fracture. Some newborn reflexes gradually weaken and disappear over a period of months. Sensory assessment. Ears. The ears are assessed for placement, overall appearance, and maturity. An imaginary horizontal line, drawn from the outer canthus of the eye, should be even with the area where the upper ear, helix, joins the head. Low-set ears may indicate chromosomal abnormalities. The ear should be almost vertical in placement on the head. The nurse examines the ears for skin tags and pre-auricular sinuses and dimples. If they occur with any other abnormalities, renal ultrasound is often performed. Abnormalities of the ear may indicate chromosomal abnormalities, hearing problems, or kidney defects. The stiffness of the cartilage and degree of incurving of the pinna are checked as part of the gestational age assessment. Hearing begins to develop by 23 to 24 weeks of gestation. Infants can hear by the last trimester of pregnancy, and their hearing is very good after birth. Hearing is assessed by noting the infant's reaction to sudden loud noises, which should cause a startle response. Infants should respond to the sound of voices and prefer a high-pitched tone of voice and rhythmic sounds. They will turn toward the sound of the mother's voice or another interesting sound. A hearing screening is performed before discharge for most birth facilities. Eyes. The eyes are examined for abnormalities and signs of inflammation. They should be symmetric and of the same size. The iris is dark gray, blue, or brown, but may change color by 6 months of age. Slanting epicanthal folds in a non-Asian infant may be a sign of trisomy 21 or other abnormal conditions. Edema of the eyelids and subconjunctival hemorrhages, reddened areas of the sclera, result from pressure on the head during birth, which causes capillary rupture in the sclera. The edema diminishes in a few days, and the hemorrhages resolve in 7 to 10 days. The sclera should be white or bluish white. A yellow color indicates jaundice. A blue color occurs in osteogenesis imperfecta, a congenital bone condition. Conjunctivitis may result from infection or a chemical reaction to medications. Staphylococcus, chlamydia, and Neisseria gonorrhoeae are common organisms that cause infection. Maternal gonorrhea can cause infection of the infant during birth. The resulting ophthalmia neonatorum may cause blindness. To prevent this condition, all newborns are treated prophylactically with antibiotics to the eyes. Any discharge from the eyes is reported for possible culture and treatment. Transient strabismus, crossed eyes, is common for the first 3 to 4 months after birth because infants have poor control of their eye muscles. The doll's eye sign is a normal finding in the newborn. When the head is turned quickly to one side, the eyes move toward the other side. The setting sun sign, the iris appears low in the eye and part of the sclera can be seen above the iris, may be an indication of hydrocephalus. The pupils should be equal in size and react equally to light. Cataracts, opacities of the lens, appear as white areas over the pupils. They may develop in infants of mothers who had rubella or other infections during the pregnancy. When a light is directed into the eyes, the normal red reflex may not be seen if large cataracts are present. Tears are scant or absent for the first 2 months of life. Excessive tearing may indicate a plugged lacrimal duct, which is treated with massage or surgery. Visual acuity is approximately 2400. The eyes cannot accommodate well, but newborns should show a visual response to the environment. They should make eye contact when held in a cradle position during a period of alertness. Although they focus best on objects that are 20 to 30 centimeters, 8 to 12 inches away, they can see objects to a distance of 76 centimeters, 2.5 feet. They should respond well to human faces and geometric patterns of black and white or medium bright colors, but show little interest in pastel colors. Newborns should blink or close their eyes in response to bright lights. Any infant who does not respond to visual stimuli should be reported to the physician or nurse practitioner for further investigation. Sense of smell and taste. The sense of smell is demonstrated when infants recognize breast pads soaked with their mother's milk and differentiate them from pads soaked in water. Their ability to distinguish taste is shown by their preference for sweet liquids and aversion to sour or bitter tastes. Other neurologic signs. The newborn is assessed for tremors or jitteriness. If tremors are present, the blood glucose should be checked because hypoglycemia is the most common cause. If blood glucose is within normal range, the cause may be low calcium or prenatal exposure to drugs. Tremors increase each time the infant is touched or moved, but stop briefly if the extremity is flexed and held firmly. Seizures indicate CNS or metabolic abnormality. To differentiate between tremors and seizures, the infant's extremities are held in a flexed position. This causes tremors to stop, but a seizure continues. Seizure activity also may include abnormal movements of the eyes and mouth and other subtle signs. Any infant thought to be having seizures is referred for further assessment and treatment. The pitch of the cry is important. Cries that are shrill, high-pitched, hoarse, and cat-like, mewing, are abnormal. These cries may indicate a neurologic disorder or other problem. Normal infants respond to holding and are quiet and appear content when their needs are met. Rocking motions are often effective in quieting an irritable infant. Most infants nestle or mold their bodies to that of the people holding them, making them easy to hold and cuddle. Neonates who stiffen the body, pull away from contact, or arch the back when held may be showing signs of CNS injury. Infants should react to painful stimuli with crying and an increase in vital signs. Excessive irritability also may be a sign of injury to the CNS. All such abnormal signs are reported for further neurologic assessment. Hepatic System. The major early assessments of the hepatic system are related to blood glucose and bilirubin conjugation. Blood glucose. The nurse must be alert for newborns at increased risk for hypoglycemia, which can cause brain damage. Factors that might have caused the infant to deplete available glucose are noted. A quick estimate to determine whether the newborn appears to be near term and of appropriate size for gestational age is performed at birth. Observing for signs of hypoglycemia is necessary throughout routine assessment and care. Early signs include jitteriness and other CNS signs and signs of respiratory difficulty, a decrease in temperature, and poor feeding. Some infants with hypoglycemia show no signs at all. Screening for blood glucose is not necessary for normal term infants. Those in risk categories or showing early signs should be screened. Normal blood glucose for the term infant during the first day of life is 40 to 60 milligrams per deciliter and 50 to 90 milligrams per deciliter thereafter. Because capillary blood is used in screening tests, these tests are less accurate than laboratory tests using venous blood. Therefore, a laboratory analysis should be used to verify readings of 40 to 50 milligrams per deciliter or below. Avoiding injuries to the infant's foot is important when taking blood from the heel. If the lancet goes into the calcaneus bone, osteomyelitis may result. Commercial devices for heel punctures are designed to puncture the heel to the proper depth. They are available for full-term and preterm infants. The site chosen must avoid injury to major nerves and arteries in the area. Other complications include cellulitis, abscess, scarring, bruising, and pain. Infants are often fed if the reading is 40 to 45 milligrams per deciliter or less to prevent a further decrease in glucose, especially if the infant shows signs of hypoglycemia. The blood glucose is rechecked 30 to 60 minutes after the feeding and again before feedings until the results are acceptable or according to hospital policy. Infants who are in risk categories are usually monitored for 12 to 24 hours after birth. Bilirubin. The nurse assesses for jaundice at least every 8 to 12 hours and is particularly watchful when infants are at increased risk for hyperbilirubinemia. Jaundice is identified by pressing the infant's skin over a firm surface, such as the end of the nose or the sternum. The skin blanches as the blood is pressed out of the tissues, making it easier to see the yellow color that remains. Jaundice is more obvious when the nurse assesses in natural light. Jaundice begins at the head and moves down the body, and the areas of the body involved should be documented. Jaundice becomes visible when the bilirubin is greater than 5 milligrams per deciliter. Jaundice appearing before the second day of life may indicate the bilirubin level is rising more quickly and to higher levels than normal and may not be physiologic. The physician or nurse practitioner may order laboratory determinations of the bilirubin level based on the nurse's assessment. In many facilities, protocols allow the nurse to obtain transcutaneous bilirubin measurements using a bilirubinometer or laboratory measurement of total serum bilirubin, TSB, before notification of a nurse practitioner or physician. A bilirubinometer is a non-invasive device to measure bilirubin in the infant's skin, thus avoiding repeated skin punctures to obtain blood samples. Obtain TSB or TCB measurements on all infants jaundiced within the first 24 hours. If serial bilirubin assays are ordered, the nurse notes changes from one reading to the next and correlates the results with the infant's age. Abnormal results of TCB should be confirmed by measurement of TSB. Charts are available that show the degree of risk for infants at different ages, in hours, by the level of TSB. The AAP and ACOG recommend obtaining TSB or TCB measurements on every infant before discharge. This helps determine whether discharge should be delayed or early follow-up arranged. All abnormal results should be documented and reported to the nurse practitioner or physician. Application of the nursing process in the care of infants at risk for hyperbilirubinemia is covered in Chapter 21, and a discussion of phototherapy is in Chapter 24. Gastrointestinal System. The initial assessment of the gastrointestinal tract occurs during the first hours after birth, when the nurse observes the parts that can be seen and the infant takes the initial feeding. Mouth. The mouth is inspected visually and by palpation. Some infants are born with precocious teeth, usually lower incisors. If the teeth are loose, the physician usually removes them to prevent aspiration. Epstein's pearls may be present on the hard palate or gums. These small white hard inclusion cysts are accumulations of epithelial cells and disappear without treatment within a few weeks. They are a form of milia. The nurse examines the tongue for size and movement. A large protruding tongue is present in hypothyroidism and some chromosomal disorders. Paralysis of the facial nerve affects the movement of the tongue and causes unilateral drooping of the mouth, noticeable during crying or sucking. The tongue may appear to be tongue-tied because of the short frenulum, but this is normal and usually has no effect on the infant's ability to feed. In a true tongue tie, there is limited tongue movement. Clipping of the frenulum seldom is practiced because of the potential for infection. Although candidiasis, thrush, is not apparent in the mouth immediately after birth, it may appear 1 or 2 days later. The lesions resemble milk curds on the tongue and cheeks that bleed if attempts are made to wipe them away. Newborns may be infected with Candida albicans during passage through the birth canal if the mother has a candidal vaginal infection. The infant is treated with antifungal medications such as nystatin suspension. A cleft lip or palate results if the lip or palate fails to close. Cleft palate may involve the hard or soft palate, or both, and may appear alone or with a cleft lip. The palate is inspected when the infant cries. A gloved finger is inserted into the mouth to palpate the hard and soft palate. A very small cleft on the soft palate may be missed if only a visual examination is done. Suck. The normal full-term infant should have a strong suck reflex, which is elicited when the lips or palate are stimulated. The reflex is weaker in the neonate who is preterm, is ill, or has just been fed. The newborn's cheeks have well-developed muscles and sucking pads that enhance the ability to suck. These fatty sucking pads last until late in infancy, when sucking is no longer essential. Blisters may be present on the newborn's hands or arms from strong sucking before birth. Initial feeding. The initial feeding is an opportunity to further assess the newborn. If the mother is breastfeeding, she should begin in the first hours after the birth. The nurse can observe the infant's response unobtrusively, while assisting the mother to position the infant. To decrease regurgitation from overdistension of the stomach, an initial formula feeding should be no more than 1 ounce. The nurse evaluates the infant's ability to suck, swallow, and breathe in a coordinated manner. Although the fetus sucks and swallows in utero, these acts may not have been performed together. The addition of breathing to sucking and swallowing is a new experience. Some newborns choke or gag during the first feeding. Others may become dusky or cyanotic because they become apneic while feeding. In either case, the nurse should stop the feeding immediately, suction if necessary, and stimulate the infant to cry by rubbing the back. Most full-term infants learn to coordinate sucking, swallowing, and breathing very quickly. Choking, coughing, cyanosis, or excessive oral secretions may indicate closure of the esophagus, esophageal atresia, or a connection between the trachea and esophagus, tracheoesophageal fistula. Neonates who continue to have difficulty with cyanosis during feedings may have a cardiac anomaly. Further assessment and referral are necessary. Abdomen. The abdomen should be soft and rounded and should protrude slightly, but should not be distended. The stomach may be distended by mucus, blood, and amniotic fluids swallowed during birth. An abdomen so distended that the skin is stretched and shiny may indicate obstruction. If the abdomen is distended, the nurse should measure the abdominal circumference periodically to note changes. The measurements should be recorded and reported to the healthcare provider. Loops of bowel should not be visible through the abdominal wall. Visible loops could indicate that air and meconium are not passing through the intestines normally. A sunken or scaphoid appearance of the abdomen occurs in diaphragmatic hernia, in which intestines are located in the chest cavity instead of the abdomen. This condition interferes with development of the lungs, resulting in respiratory difficulty at birth. The nurse listens over the abdomen for bowel sounds, which usually appear about 15 minutes after birth. Bowel sounds heard in the chest may indicate diaphragmatic hernia. An umbilical hernia occurs when the intestinal muscles fail to close around the umbilicus, allowing the intestines to protrude through the weak area. The condition is more common in low birth weight male and African American infants. By the time the infant is walking well, the muscles are usually strong enough that the hernia is no longer present. Sometimes umbilical hernias require surgical repair. Palpating the abdomen is easiest when the infant is relaxed and quiet. The abdomen should feel soft because the muscles are not yet well developed. Masses may indicate tumors of the kidneys. Palpation of the liver and kidneys usually is not part of routine nursing assessment of the abdomen, but is performed by the primary care provider. The liver is normally 1 to 2 centimeters below the right costal margin. If the organ seems large, it should be reported to the physician or nurse practitioner because it may be a sign of congestive heart failure or congenital infection.